Welcome everyone to our Kernel of Knowledge session. Today's webinar is going to be talking about financial health literacy. I'm Bobby Newman from the National Network of Libraries of Medicine, Greater Midwest Region Office here at the University of Iowa, and I...
Go down right now.
Ooh.
Goodbye.
And I do outreach for public libraries in our 10-state area. Just a reminder about a couple housekeeping things. All attendees are automatically muted to cut down on background noise. So if you do have a question, please use the chat box. You might need to exit full screen mode in order to see the chat box. And be sure to select all participants from the drop-down menu so that everyone can see your chat. I'll be monitoring the chat box during the session, and I'll be reading out questions to ask Heidi at the end. We do record our sessions, and it will be posted on the NNLM YouTube channel for future viewing. If you would like closed captioning, you can find that on the More drop-down menu. And with that, I'm going to stop sharing my screen and let Heidi share hers so that we can see her slides.
Okay, so how's that looking? Can you see the slides?
No.
No? Looks like I've lost my Zoom navigation here.
There we go.
All right.
There we go.
All right, how's that?
It looks great, Heidi.
Good. Okay. Well, thank you. And thanks to everyone for joining us this afternoon on a Thursday. That's dedication. I'm bringing a number of different perspectives to this presentation today, from experience as an academic librarian in health sciences librarianship, reference service, and an interest in health literacy and plain language writing. But probably most importantly, I'm speaking to you today as a fellow healthcare consumer navigating the sometimes really challenging aspects of our healthcare system. And I call this the elephant in the room because we don't often talk about financial health literacy as a component of health literacy, but it's a really critical factor that affects our ability to create a culture of health in our communities. We're going to look at a number of different areas and perspectives today so that you can think about the needs of your community, possible partnerships, and things that you might want to explore more deeply. And I've also designed these slides to serve as a resource for you in the future. Specifically, we'll talk about the current realities in our communities, who's affected, what financial health literacy is, some personal stories that illustrate those components of health literacy, looking at some challenges and barriers, and most importantly, how librarians can help. So as we look at this topic today and explore different aspects of health literacy, ask yourself, how confident are you in managing your healthcare expenses, including paying bills? And how confident might you be in some of the scenarios that we talk about? Particularly in public reference service, consider that sometimes the questions that you receive might be based in part on issues that are related to financial aspects of healthcare, even if those aren't directly articulated. So this is a snapshot of kind of the current landscape of things that are converging and going on in dealing with the realities of paying for and managing our healthcare today. See that the average cost for healthcare in 2019 continues to go up. Almost 50% of Americans are not covered by employer-sponsored health insurance, which means that they have to go out in the marketplace and find their own. Growing number of GoFundMe campaigns are for medical expenses. 1 in 3 is a pretty significant amount. In other background information, for about 13 years, the Commonwealth Fund has been conducting a biennial health insurance survey. And in their most recent survey in 2016, they found that 29% of adults who had coverage for the full year reported not getting care because of cost. So you have coverage, but you're still not using it. And people with individual market coverage continue to report cost-related access problems at higher rates than those with employer coverage. Perhaps not surprising. We're often told that healthcare costs are the result of overuse, but in the same survey, the Commonwealth Fund also found that Americans on average go to the doctor 4 times a year. And that's less than the Dutch, who average 8 visits, Germans with 9.9, and Japan with 12.8. So when we do seek care, we have less face time and shorter hospital stays than our international counterparts. If you're interested in seeing the data that they've collected over the 13 years that they've been doing this, they have a health insurance survey data explorer that provides a platform that you can explore and slice according to 8 different financial areas of impact. It's very visual. They've done a good job with it. It's in the resources section. I'll point that out when we get to that. So at the same time, financial advisors such as Fidelity are currently counseling individuals to have, wait for it, $280,000 tucked away for retirement just for medical expenses. So that's not even your retirement income to live off of. Now, how many people have that saved just for retirement? Medical bankruptcies are also rising, and researchers and studies disagree on the exact number. They cite ranges from 26 to 62%. But if the Kaiser Family Foundation in 2015 found that roughly 26% of Americans between the ages of 18 and 64 struggled to pay medical bills. So it's a significant number. And it's also important, I think, to consider the broader aspects of bad health events beyond the narrow scope of bankruptcy, because you've also got things such as lost income and job loss. The drug costs are a trend that's also continuing. For 2019, the Wall Street Journal reported in January that they're hovering around 10%, with an average increase of 6.3%. And probably not surprisingly, to hear that the UK-based advocacy groups such as T1 International, they advocate for people with diabetes, have noted that Americans pay more for insulin than people in any other nation. So that brings us to the point on the far right side, which is that 9 out of 10 folks lack the skills to manage healthcare. And this is based on a national assessment of adult literacy that was commissioned by the US Department of Education. For the first time in 2003, they looked at health literacy specifically. And since then, 2011, 2012, they did another large-scale assessment of adult skills that they called the Program for International Assessment of Adult Competencies. And it still bears out these numbers. So you can see that there's a worrisome contradiction here. We've got low health literacy skills coupled with increasing cost burdens and complex decisions for consumers that many of us are ill-equipped to handle. So who's affected? Well, we're all affected. Particularly vulnerable are older adults over the age of 65, people with low education levels, people with incomes at or below the poverty level, refugees and immigrants, non-native speakers of English. But I think it's important to note that people of all ages, races, incomes, and education levels are affected by limited health literacy. And the reason for that is because health information and services are often unfamiliar, complicated, and technical, even for people with higher levels of education. So not surprisingly, if you have lower levels of health literacy, that results in poorer health status and mortality. And at the same time, lower levels of financial literacy are associated with lower earnings and fewer savings and investment behaviors. And the problem of low literacy among older persons represents a significant public health challenge because older adults carry a disproportionate burden of disease and hold a large portion of the nation's wealth. So even though we're being called upon to make difficult and consequential medical decisions throughout our lives, there's not a lot of research that's been done on the actual influence of financial and health literacy on those decisions and outcomes. So what does this look like in practical terms? Well, surveys confirm what we suspect, that people have trouble understanding insurance terms and even larger problems with the ability to calculate cost sharing. About 75% of Americans report that they know how to use health insurance, but only 1/5 could calculate the cost of a routine doctor visit. The Kaiser Family Foundation also found that 79% of people knew that a health insurance premium has to be paid each month, and 72% were able to identify the correct definition of a deductible. However, it's the calculations that really cause folks problems. They found that only about half could correctly calculate the out-of-pocket costs for a hospital stay involving a deductible and copay, and only 16% were successful in determining the cost of an out-of-network lab test with a capped allowable charge. So those are the circumstances where not being able to calculate that really can land you with some unexpected and crippling financial burdens. So this brings us to the work of McLeod, Musich, Hawkins, and Armstrong. They have examined this concept of financial health literacy that arises out of the need to be both financially literate and health literate. And while they focused on the elder population, I think that their work is more universally applicable to all stages of life. And so I've adopted their definition and framework as a way to begin thinking about this topic. So financial health literacy then is understanding the financial dimensions of treatment options and our healthcare needs, and integrating those with the other life choices and financial planning that we need to do and maximize our quality of life. The authors constructed 4 components of financial health literacy that you see here, and they involve the capacity to understand and apply financial information and available financial resources to make these sound healthcare treatment choices while also managing our other household expenses effectively. And research indicates that financial health and health insurance literacy are really closely intertwined and especially impactful in terms of later life decision making. There's some fluidity between these categories, so I really like to think of them as guideposts. So before we ever start using insurance, we need to understand how the system works, the options available to us, and weigh those against our needs. And at every point along the healthcare services spectrum, the healthcare system behaves in a way that requires patients to read and understand important healthcare information, and that includes financial information. That information can be dense, technical, and jargon-filled. So as a result, that healthcare system itself can pose a really serious barrier to appropriate care at this very first step. And you can see here some of the components of that process of understanding the terminology, determining what your needs are, what your expenses might be, what prescription drug coverage might be available, understanding medical care options, providers, and locations. Are you geographically bound? Do you live in a remote or rural area? Estimating long-term healthcare expenses, and understanding the financial implications of specific treatments and medical conditions. So if we look at that, one of the barriers is understanding care options, and that can lead to rationing. Nicole Smith Holt and other mothers have been sharing the stories of their children, young people who have lost their lives due to insulin rationing. You might have heard the story of her son, Alex Smith, in the news. He could not afford the $1,300 a month out-of-pocket insulin costs when he turned 26 and had to leave his mother's health insurance plan. Both he and a young woman named Antavia Warsham died because they couldn't afford their treatment, and they tried to ration their insulin until their next paycheck. While companies do offer some savings and assistance programs, patients don't always know about them. And I think it's noteworthy that Warsham's mother has gone on to found a nonprofit that raises awareness about the issue of insulin access and provides financial help to patients with diabetes who can't afford treatment. But this is a citizen taking this on. So challenges to this aspect include, understanding the terminology, the industry jargon. The model has definitely changed from an approach of the patient as a passive receiver of information to one where it's so imperative for us to advocate for ourselves and our care. And the choices and options can be truly dizzying. You may be familiar with HMOs and PPOs, but what about an EPO? Have you heard of that? That's an exclusive provider plan that can have a very narrow network with dire financial consequences if you go outside of that network. Consumer-directed health plans are also showing up. And these offer high deductible health plans paired with a spending account for out-of-pocket costs, such as health savings accounts or integrated health reimbursement arrangements. And the goal for those is to save money and lower healthcare utilization, but in reality, those accounts may not be adequately funded, and people avoid seeking care. They face increased risks and greater financial vulnerability. It can also lead to expensive conditions down the line, including avoidable hospitalizations and long-term spending on chronic diseases. There's also something known as the Medicare donut hole, and that refers to the coverage gap in Medicare Part D prescription drug benefit. And that's the point where the prescription drug expenses exceed the initial coverage limit of the plan, and you have not yet reached catastrophic coverage level where the coverage kicks back in. There's a bipartisan Budget Act of 2018 provision that's looking at closing that donut hole. We'll see what happens with that. So financial scenario planning and calculations, the ability to do that is really important at this first step because if you misjudge, you can really miss the mark and end up with much higher financial costs than you were expecting. Again, complexity and lack of transparency makes it difficult to determine the type of plan that best meets your needs. This is all confusing if you're a native speaker of English. Imagine if English is not your first language. And then where can we turn to get help to figure some of these things out? So once healthcare needs are determined, we match them with our available financial resources, and this can affect the choices and care resources available to us. We make our best guess to choose the appropriate insurance plan. We're expected to review and change insurance or pharmacy plans if necessary, to know about and explore supplemental things such as the HSAs and flexible spending accounts that might help us. If we have a recommendation for specialty testing, being able to figure out if that's something we really need and can afford or if it's unnecessary, planning for end-of-life care choices, and independently choosing appropriate treatment and medical care options. And I have that asterisk because sometimes we don't have a choice, and that becomes an issue. So this sounds straightforward, but the realities can require very difficult decisions. Kristen Kilmer is an example of that. She's a success story for precision medicine, which is very exciting. Doctors customized her breast cancer treatment to her own unique DNA. However, that type of cutting-edge approach is generally considered experimental, and that leaves patients to pay for those treatments on their own. In her case, the cost burden included 12 hours of round-trip travel monthly to participate in a clinical trial, and the drug assistance for her treatment was abruptly cut off by the drug company. And that left her to ask the question on the slide. When you're looking at your daughter, you ask yourself, do I take a medication that might allow me to see her graduate high school, or do you stop taking it to avoid causing her financial harm? And that's a question that many cancer patients find themselves asking. The American Journal of Medicine published a study where the authors found that 42% of patients depleted 100% of their assets within 2 years of receiving a diagnosis. And that's an average loss of $92,000. And that sentiment is echoed by Mark Els, who's the CEO of the biotech company Celgene. He gave a keynote at the Life Science Washington Summit, where he pointed out that the financial burden of treatment is eclipsing the biological challenges of treating cancer for many patients. So we have the knowledge, but it's not affordable for folks, or it's financially crippling. So it becomes clear that managing this delicate balance between care and cost requires engagement and resources, and whether or not you have access to resources and information makes a huge difference. And access to that kind of critical information is neither transparent nor consistent, or sometimes even reliable. If anyone has gone to their healthcare provider's website to check and see if someone is in network, you know that those can change monthly. Sometimes they're not updated. And you may be in the middle of treatment and suddenly your provider goes out of network. It can be difficult to get cost information in advance. And as we saw in Kristen Kilmer's example, life-saving experimental treatments can be financially devastating. And as we'll discuss in a few slides, in an emergency situation, you may not be able to make an independent decision. Managing healthcare expenses. So this is where everything comes together. The realities of managing what we need, what we can afford, and what we end up having to spend, sometimes unexpectedly. So managing that monthly budget for our healthcare, along with other household bills and things that come up unexpectedly, thinking about or planning for lost work and income, dealing with long-term illness, and advocating resources that might be available, or identifying advocate resources in our state and community that might be available to us. So consider the case of Nina Dang, who had a biking accident and found herself in the Zuckerberg San Francisco General Hospital ER. And I think this just happened not too long ago, maybe December. That is the only top-tier trauma center in the city. The problem is that this ER doesn't participate in the networks of any private health insurers. Everybody is out of network. So Dang left the hospital with a splint, pain medication, a referral to an orthopedist, and $20,000 of a $24,000 bill. So we've heard about this happening with outpatient and diagnostic facilities, but individuals in an emergency situation are particularly vulnerable to out-of-network charges, because they may not have a choice in where they're taken for care. You can be unconscious, or there are folks that knew they would be out of network and asked to be taken to an in-network hospital, only to be refused treatment because it was determined they needed level 1 trauma care, and so they're again in an out-of-network situation. So after the story was published in early January, the Zuckerberg San Francisco General Hospital reached out to her and informed her that her bill would be reduced to $200, which is her plan's regular copay for an ER visit. Additionally, the San Francisco Board of Supervisors, which oversees the hospital, is now planning hearings on its billing practices. So although studies have shown that greater knowledge about health insurance and financial issues increases the likelihood of gaining coverage, her story is an example that it's still not a guarantee that the medical bills themselves are manageable, even among individuals with higher incomes. If you recall, Nobel Prize-winning physicist Leon Lederman, he sold his Nobel Prize in auction in 2015 in order to help pay for his medical bills and care. So again, I think this points to the fact that many people can benefit from incorporating financial health literacy into the concept of health literacy. So as we've seen, another challenge to managing healthcare expenses is to expect the unexpected. The narrow networks, having the information to know when an experimental treatment might benefit, emergency situations that remove choice from the equation for us, lost income, lost jobs, and in an effort to create some transparency, the government, as of January 1st, started requiring that hospitals have to make detailed prices for materials and procedures available online. So theoretically, everything ranging from the cost of an overnight stay in a hospital bed to a single tablet of Advil or the stitches you might get in an emergency room was supposed to be posted. In reality, it's not quite working out that way. It's currently not all that helpful because the price lists don't give a simple number for common procedures. They break down every part of a procedure item by item in no particular order, and they're labeled with codes, acronyms, and abbreviations. So that's just not understandable to a layperson. Secondly, these price lists, which are called charge masters, are the hospital equivalent of the car sticker price. So they represent what the hospital would like to be paid for a service, but not the price that most customers or consumers actually do pay, or the prices that have been negotiated by the insurance company. So which services, treatments, drugs, or procedures that a patient will face in a hospital stay is often unknowable. So for now, we're still in the dark. Hopefully, using technology and working with this data now that it's slowly becoming available, perhaps that could yield something a little more useful. And finally, we arrive at the point where we pay for the healthcare services that we've used. So that generally means understanding and paying our medical bills while also juggling our household bills and other living expenses, and then understanding our health plan's appeal process or where we can go to get more information if we have questions about things or we need to have some things answered and dig a little bit deeper. And this story is an example of how diligence doesn't always protect consumers from surprise medical bills. This is Scott Cohen, who woke up in an emergency room in downtown Austin, Texas, with his jaw broken in 2 places. And while awaiting surgery, now picture this, you're on a gurney waiting for surgery and feverishly checking your phone to make sure that you're in an in-network facility. While the hospital that he was in was an in-network facility, it turned out that his oral surgeon who worked in the ER was not. and that's how he ended up with a $7,900 bill, which his healthcare promptly declined. So this practice, where the hospital then holds the patient financially accountable for the balance, is known as balance billing. And patients are stuck unless they live in a state with laws regulating that type of billing. Texas is where Cohen happens to live. They have a very high rate of out-of-network bills, something like up to 34% of the ER visits, which is incidentally 20% above the national average. Journalists started asking the surgeon's office about the charges for an article that she was writing, and they were ultimately dropped. But had that not been the case, Mr. Cohen would have had to know about a 2009 Texas law allowing him to contact the state's Department of Insurance to initiate a dispute resolution. Otherwise, he would have been on the hook for the whole thing. These types of stories inspired a journalist named Sarah Cliff of Fox Media to start a crowdsourcing project. And they collected 1,330 bills from all 50 states for visits between 2012 and 2018 in the hopes of shedding light on some of these emergency room costs, particularly facility fees, which are the price for walking into the door and seeking service. That project ended in December of 2018, and I've posted a link to the data that she collected in the resources section if you'd like to explore that. Some interesting stories and examples in there. She also hosts a podcast called The Impact, and she estimates that so far the project has saved patients about $45,000 in medical bills being reversed. So definitely a benefit to shining a light on some of those stories for folks. NPR and Kaiser Health News have also undertaken a project called Bill of the Month. It is not limited to ER, it's more general in scope, and they're investigating and dissecting real-life medical bills in an attempt to help people be more successful and active in managing their healthcare costs. So this closer media scrutiny has spurred several draft proposals in Congress, and those have the potential to perhaps address some of these types of billing issues. And I think one's been introduced by Senator Bill Cassidy, who's also a physician, so we'll have to keep an eye on those. So in summary, cost burdens continue to shift to the consumer. These surprise facility fees, this balance billing unless it's addressed, not readily knowing what's reasonable and customary. And I'd like to draw your attention to some of the billing practices that are happening too. There's kind of an emerging practice now of providers requiring a credit card on file. So after the health insurance pays, whatever's not paid within 30 days immediately goes onto the credit card. So if you have several $1,000s, that's a very high interest situation and can certainly be financially crippling. Things I'm hearing are also much more quickly sent to debt collection, so there's not a lot of time being given before people have to deal with that. And again, higher deductibles and shares of costs, and as we saw in the statistics for GoFundMe, excuse me, that providers are actually pushing patients to raise money on social media platforms as a solution. Certainly not long-term sustainable. So some of the stories we've talked about are a little heavy, and I know the whole subject can be overwhelming, but here's the good news. How can we help? And I think we can. Librarians are can-do folks. So there are a number of areas that I think that we can help in, and I've split those out into educating, partnering, and empowering. So thinking about ways that we can include the financial aspects of health literacy in our collection development work, what kinds of special collections or repositories of patient education information, insurance, and community resources can we put together? We can take a page from the universal precautions borrowed from disease management and operate from the level of knowing that interventions and materials that address health literacy barriers for vulnerable individuals with limited health literacy also help people with higher health literacy levels. So everyone benefits. And given the options, some individuals even prefer this level of information. Targeted communication is another area. Targeted communication is adapted to meet the needs of specific groups of people, such as patients with limited literacy skills. And I think that NNLM also does a really good job of providing courses such as Stand Up for Health that allow us to learn about places where we can really dig in and get some of this community level statistical information so that we can do targeted communication. And again, important for that to be multilingual because not everyone has English as their first language. And as I mentioned, with training opportunities, always looking for ways to improve health information seeking and decision-making skills. We can also think about partnering with folks. So co-programming with local public health, patient, consumer, financial advocacy groups, legal resources. I'd like to mention that I've sent out a link in the chat box for a resource that PLA has made available, and it's part of the libraries Connecting You to Coverage program that they have. And they have a whole host of resources, including kind of a programming checklist for something they call health insurance understanding. So some great things available there. And I think there are also some grants available, so definitely check that out. We can raise awareness of resources such as community-based healthcare providers, drug assistance programs. If the young people that died of insulin rationing would have had somewhere to turn in their community or have known about it, that might have been prevented. Toolkits and outreach initiatives. So in addition to what PLA and ALA have been doing, there's the Libraries Transform Health Literacy Toolkit in addition. And April is National Financial Literacy Month, so a great time to maybe think about ways to highlight and work with this topic. There are also lots of exciting citizen science initiatives. I think yesterday there was a webinar put out by NLM on citizen science, and April 13th coming up is Citizen Science Day, where you can actually participate in hands-on programs and learn a little bit more about that. So grassroots action. We can also share specific steps to take action and align information with services and supports available in our own communities. And I think so importantly, telling stories of impact. If we get the stories out there and people's real lived experiences come to light, that is very powerful for creating action, creating change, getting things to start moving. We can create networks with specialized partners such as our academic libraries, medical and consumer health libraries, and all types of other agencies and allies. And also leveraging technology to deliver services and information and come up with unique solutions. So one example of unique partnering and ways that we can come together to address this type of challenge is Dr. Jim Bailey, who's a physician and professor of internal and preventative medicine at the University of Tennessee Health Sciences Center, has been leading a panel discussions called a Healthy City Town Hall Meeting. So he's used his expertise and experience to also try to bring together people in communities and talk about ways that we can organize our own health city collaboratives to take charge of health and healthcare resources. He's also written a novel that won the Benjamin Franklin Award called The End of Healing. So it's a novel, but it looks at, through the eyes of a young medical student, more about the history of how we've gotten here, the history of our medical system. It's interesting. So this brings us to some of the resources I've put together about financial health literacy, and just a few that I'd like to point out and highlight. I've got tried to follow the categories that we had, but as I said, these are fluid. So coverage to care is multilingual. So if you're looking for multilingual resources, that's definitely one to look at. I really like understanding health insurance because that gives a lot of terminology. It was put together by people that do medical coding and billing, so they've definitely got some insight into that aspect. There's a guide to understanding your health insurance policy, again, with good information that clarifies confusing terms. Questions to ask your doctor, which is also in Spanish. The National Association of Area Agencies on Aging just has a whole host of resources as well. And of course, there's healthcare.gov. On the local level, the states have access to something called SHIP, which is the State Health Insurance Assistance Program. So that provides some good local connections for folks. And I want to make sure to mention HealthReach, which has multicultural patient education and health materials in a lot of different languages. And Medline Plus also has information. And the PLA link that I sent out through the chat also does a really good job of having some multilingual resources. The Choosing Wisely app was shared with me by Dr. Bailey, and this is a really interesting one where it's an app for if you need special testing and you're not sure if it's a good idea or if it's a best practice. The physicians in the medical societies, the medical specialty societies, got together and identified tests and procedures commonly used in their field. Try to give you an idea of what you might consider if that's been brought up for you. CAPRO is a free resource for people with Medicare that provides information and assistance. There are also things such as the health insurance marketplace calculator. So some of the importance that we talked about with scenario calculations, this can help with some of that. And related to that, we have the Your Money, Your Goals toolkit. So also makes different personal financial management tools available. And I like that that one's also available in English, Spanish, and Chinese. The development of tools such as Fair Health and the Healthcare Blue Book are exciting because they're taking some of the information that they're able to get their hands on by looking at bills, and they're creating kind of the equivalent of the Kelly Blue Book for cars. So to give you a place to start at least trying to figure out some comparative pricing so that they can see geographical trends. So, yes?
I went ahead and nobody should be talking but Heidi, so
we'll okay. I didn't know if there was a question or something that came up.
I'm not sure what happened.
So those look for more of those kinds of tools to show up, and I think those are a good starting point right now. The Health Insurance Survey Data Explorer is what I mentioned earlier, where the Commonwealth Fund was looking at 13 years of insurance data and they have just a great visualization tool that you can explore. I've got some resources here that also list places to consider for donated services such as dental, some things at the state level that can help with emergency care. There's remote area medical, some information about dealing with healthcare and credit cards, listing of state and federal programs that might have resources to help paying medical bills, some additional information on understanding the billing and how to read it and deal with billing errors, some consumer assistance programs, some medical pharmacy cost helps, prescription assistance. And as we saw in the case of Texas, sometimes knowing to go to your state insurance department can be really helpful. they can help with filing complaints or point folks in the right direction, particularly when there are specific laws like there are in Texas where you would have had to know about it to get some help. And finally, think the transparency issues initiative. So this kind of is maybe a little bit in line with citizen science, but the Vox ER Bills Project and the NPR Kaiser Health News Bill of the Month, things like that where we share the stories and people's experiences, I think can be very helpful and illuminating. So I was diligent in my research, so there are lots of references for you to poke through if you are so inclined. And I hope that this has been helpful in giving you an overview of this concept of financial health literacy and how we might think about that in the bigger context of health literacy, and that there are things that we can do to help our communities and to shed some light on this and get folks connected and create healthier communities, because information is everything. So thanks for your attention.
Great, Heidi, thank you so much. This was wonderful and really interesting. These are all things I was sort of peripherally aware of, but you really brought it together nicely. We've got some time for questions now. If you have questions, please go ahead and type your question into the chat box. You may need to exit full screen mode in Zoom in order to find the chat box. But while we're waiting for that, Heidi, let me ask a question. I know we talked a little bit about you doing research for this. What was the, I guess, most surprising thing that you came across while you were doing this?
The NPR and Kaiser initiative, where they were looking at bills, had some really staggering examples. And of course, they're going to pick the larger amounts or the really shocking things. But when you look at how many there are, that's really revealing. And I remember that there was one case specifically where someone had had surgery and she had to be monitored because she was on an opioid, but didn't think to question when this was done at the physician, turns out, affiliated facility, and she ended up with a massive bill. I mean, it was, I want to say, more than $20,000. Wow. So it really brought to light the fact that you may need these types of things, but when you have no say as to where that's done, and the physician in this case ended up being investigated because he had an interest in the lab work, which would normally be, I think, something like $200. Those are things that can just be so crippling for people.
Yeah, it's amazing. I do see a question from Dustin in the chat box asking if we'll receive a copy of the presentation with the links to the resources. The answer is yes. I have a copy of the presentation handouts from Heidi, and I will be sending those out. I will probably wait till the recording is done as well and send all that out together. I don't want to spam your mailboxes.
Yeah, and if you have a chance to drop that PLA link in there in case folks weren't able to grab it for the chat, that would be great. Because I just came across that yesterday, so it was like a last little nugget that I found.
Yeah, I think that's a really great resource. It's wonderful to see this Promoting Healthy Communities sort of banner that we used when we partnered with PLA, being over additional projects. It's great.
I think that's been a fantastic program.
So somebody asks, have medical databases like NLM and Medline adapted medical jargon at all, if at all, to be more accessible, or is this the reason many individuals choose to search commonly Googled sites like WebMD?
I think that's the reason for many of the common Googling. Yeah, there's just a great divide there. Now, I did find quite a few articles in PubMed that were starting to talk about cost related to specific conditions or cost in general. So researchers are definitely looking at that, but it's not something that's readily accessible, I think, to the layperson in understandable terms.
And I would think, it's hard to know why people are doing things, even when you ask them directly. Sometimes they don't realize why they are doing things. Medline Plus actually is written pretty accessibly, around an 8th grade level, a lot of the content in there. But that's Medline Plus, not Medline, and it's not PubMed. I think really the issue is most people just don't know about Medline Plus. We still see a lot of libraries. I deal with public libraries. I still encounter quite a few libraries that don't know about it or don't have it linked to their website as an authoritative source. And WebMD pays for ads and to be sponsored in Google searches. So of course it comes up and it becomes something people are familiar with.
Yeah. And I think that's a really great point. That is a wonderful resource, and it also has multilingual options in there. So definitely something to put on your radar.
All right, anybody else? All right, well, Heidi, thank you so much for this. This was really great.
You're welcome.
All right, well, let's give like one more minute or a couple more seconds maybe for anybody else has any questions that they're typing out in chat. Continuing education credits. Yes, that link will be in the email. Yes, if you're looking for a CE certificate, the link for that will be in the email with the YouTube recording and the slides. Even if you don't need continuing education credit, we do ask that you take the survey to provide feedback on the webinar. All right.
Great. Well, let's go out there and program and connect.
Good. I love this Libraries Transform poster you picked here.
It's a good reminder.
Yep. They're so great.
Yeah. Well, thanks, everybody.
Thanks for watching. This video was produced by the National Network of Libraries of Medicine. Select the circular channel icon to subscribe to our channel. Select a video thumbnail to watch another video from the channel.